Hello, everyone. Today we are going to continue by talking about the blunt trauma to different parts of the body, ranging from the head, the face, the chest, the abdomen, the pelvis, and the extremities. Um, Blunt trauma to the head and the face usually brings about traumatic brain injury, and this can be classified into mild, moderate, and severe depending on the GCS score. So most of the time, people with the mild one have GCS score between 13 to 15, while people within the moderate um, zone have theirs between um, 9 to 12, while people with the severe one have theirs, ranging from 8 then downward. So most of the time, anybody with a GCS score of 8 and lesser, you must, you know, intubate them. You must intubate them. So we typically have a spectrum of the typical injury patterns that can happen in people that suffers blunt trauma to the head and face. And these include, I think I have it here, concussion, contusion, skull fractures, diffuse axonal injury, and different form of bleeding into the brain, hematomas, the epidural, the subdural, intraparenchymal, which I know we are very familiar with. So um, we cannot talk about um, traumatic brain injury from blunt trauma and we don't emphasize concussion. So um, concussion is just more like a mild form of traumatic brain injury, which results in a physiologic disturbance of neural function. And by the time you do your imaging, you are not going to see any structural evidence of injury, right? So what essentially happens is if somebody suddenly maybe had a motor vehicle accident or a fall injury involve hitting the head maybe against the surface or an object, right? That person can experience concussion, or maybe the person is playing, this contact sport like rugby, football, and there is like, you know, injury to the head in the process. The individual can suffer concussion, and what actually happens in them is that um, that impact to the head brings about widespread depolarization of the neurons. It reduces cerebral blood flow, leading to the anaerobic, mechanism of energy generation with formation of lactic acid. So this lactic acidosis, the reduced perfusion, the diffuse axonal depolarization kind of affect the way the nerves they fire. But you are not going to see any structural evidence of injury by the time you do your imaging. So we have to be very familiar with the way people with concussion present. So we have known the pathophysiology. It's due to a problem of the function, not a problem of the structure, right? And the first thing they usually present with is headache. So just notice that following that trauma, following that injury, they start complaining of headaches. Sometimes it might not be associated with vomiting, but vomiting might be there. But one of the constant feature of concussion is headache. Then I've classified it into the physical, the cognitive, and the emotional symptoms. So if you want to go by that physical, you see them complaining of the headaches, you see them complaining of insomnia, right? They cannot sleep, they're having headaches, they are feeling dizzy. Those are the physical symptoms. For the cognitive, they have problems with concentration, they have problems with paying attention, right? They have problems with memory. So you can tell them, for example, for concentration, you can tell them to count some figures backwards. They won't be able to do it, right? You can tell them something now, ask them later, they won't be able to recall because they are not paying attention and they have problem with memory, both the anterograde and the retrograde. So that's the cognitive. Then the emotional part, you notice that they start becoming irritable, they start feeling anxiety symptoms, and they start becoming depressed. So depression, anxiety, irritability, those are the emotional issues that they have. The physical symptoms, they start complaining of headaches, complaining of dizziness, complaining of insomnia, difficulty sleeping, and for the cognitive, impaired concentration and attention. So if you want to use that, it is fine. You might also use the letters. So A, B, C, D, right? A, B, C, D, E. So for the A, you think about stuff like difficulty paying attention, amnesia, memory issues. The B for the balance. So sometimes you might have problem with coordination. So you experience some certain, recurrent falls, stumbles. The C for the concentration. They can't pay attention. They can't concentrate. The D for the disorientation. They are disoriented, they are dizzy. Then the E for the emotional, so anxiety, depression, irritability, plus the headaches following the trauma. And by the time you do your imaging, you are not seeing anything clean, no bleeding into the brain. So you should have concussion at the back of your mind. And the pathophysiology, what is happening. And it's also important to also emphasize that individuals with concussion can experience what we call post-concussion syndrome, in which, you know, they can have this injury, they can have some mild symptoms, and later the symptoms become worse. You know, maybe after weeks after the injury, they start still having this headache, this vomiting, this no, not the vomiting, this headache, this difficulty paying attention, memory issues, disorientation, dizziness, weeks after the initial trauma. So that is post concussion syndrome. So most of the time it resolves on its own. Within like 3 months, it will resolve, right? So the way you just manage concussion is just to do your supportive treatment. So you just do it more like a symptomatic management. So if they're having headache, give them headache, analgesic like the NSAIDs. If they're having vomiting, you can give them antiemetics like ondansetron, right? And most importantly, you want to take them out of that activity that they are doing. So they need a form of physical and cognitive rest, particularly between 24 to 48 hours at least, right? So you don't tell them to be engaging in contact sports. You don't tell them to be running everywhere and stuff like that that can um affect them physically. You tell them to refrain from cognitive activities. So this is not the time to be studying for the USMLEs. This is not the time to be doing thorough schoolwork. So this is not the time to be even be looking at screens, right? So you have to limit their screen time. You have to tell them to take frequent breaks, even if they are in school. Take frequent breaks from studying, right? They have to get enough rest so that they are not becoming physically exerted. So they are not exercising, doing contact sports and the likes. Then um over the weeks you can now try to do like a gradual return to play, like gradual return to the activity, and you are going to start from the mildest to the strongest. So you can tell them to start with doing light aerobic exercise, then they can progress to doing non-contact sports, you know like maybe playing tennis, right, badminton, golf. Then from there, they can now move to the contact worlds like footballing, basketballing, rugby, and the like. So the most important thing is to do your symptomatic management initially to relieve the person of their symptoms. You want to take them out of that activity, tell them to get enough physical and cognitive rest. Then you can now re-expose them back to the activity after some few weeks, right? Like doing exercise, contact, and the like. So that is that about concussion. We also have contusion. So contusion is more like bruising of the brain. So by the time you do your imaging for a contused person, you are going to see like evidence, something that looks like bleed, like whitish opacities in the brain. So that's contusion. You don't have to do any serious management. They resolve on their own. So you just do supportive care. Then we move to the fractures. So if an individual doesn't have concussion, they can have contusions, or skull fracture. And the skull fractures are classified into about four categories. So we have the linear skull fracture, we have the depressed skull fracture, we have the diastatic or diastatic rather skull fracture, and the basal skull fracture, which we all know. That one is very common, basal skull fracture. So the linear is just that you have like a break in the skull bone, but there's no shift. So the bones are still intact, but there's a break, but they are still intact, connected together, in a straight, you know, direction. So that is linear skull fracture. Most of the time, you don't do any operative care for an individual with linear skull fracture. You leave them, you place them on supportive care. If there's any shear wound, Probably like there's a cut within the skin, you can do your wound care and you close it, right? But if somebody has a linear skull fracture and there's like displacement of the bone, the bones are distracted, are separated, or you have like multiple breaks within the bone, which is what we call the comminuted fractures, you have to do surgery. So when the bones are displaced, or where there is multiple breaks at different points, comminuted fracture, you have to do surgery for such individuals. So people with depressed skull fracture, you can have like somebody gets eaten by a bat, to the head, or there's like a blow to the head and there's depression of the skull. There's a chance of that depression, compressing on the brain parenchyma. So especially when the depression is as severe as like 8 to 10 millimeter deep, you have to do surgery for such individuals. Um, People with the diastatic fractures just means that there's separation of the suture line. So that one is very common in the younger, age group, people less than 3 years rather. So, but it's not something that is commonly talked about. Then the last one, which is very important, is the basal skull fracture, in which there's fracture of the bones that makes up the base of the brain. So the ethmoid bone, the petrous and the temporal part of the temporal bone, the sphenoid bone, the occipital bone, which we are going to talk about later. So it's very easy and we have to pay attention to them. So yeah, we have talked about the contusion, we have talked about concussion, we have talked about skull fractures. Then we have to talk about the hematomas, right? And the major hematomas that we are emphasizing here is just the epidural hematoma and the subdural hematoma. So epidural hematoma basically occurs when there is like the blunt trauma, usually to the side of the head, like around the frontal, the temporal, the parietal bone junction. So usually at the side of the head, and it's very straightforward, very very straightforward. Um, the patient can present with signs and symptoms of increased ICP, which you have here. Anybody that suffers trauma, you have to evaluate for signs and features of intracranial pressure raise, right? Particularly when there is trauma to the head. So, and we are very familiar with these clusters of symptoms of raised ICP. Very, very important stuff. So, you know, they can have, normal headaches, right? Headaches, vomiting. Those are the early signs that they usually experience. So when there's trauma to the head and there's like blood collection, there's edema, there's swelling within the brain tissue. Remember that the cranial vault is unyielding. It doesn't expand in response to pressure build. So instead of that, it's going to cone, right? It's going to kind of force itself out of that brain vault, of that cranial vault. So, and there will be compression of that shared brain tissue. So that's what happens when there's pressure build up within the cranial compartment. It doesn't give way, right? So it's not compliant. So that's the word. So there's going to be compression of the neural structures, the brainstem, the brain parenchyma, and the likes, and there's going to be problems. So headaches, you know, vomiting, those are the early symptoms. Then you can start having features of the Cushing triad, which we all know, which includes the hypertension, the bradycardia, the irregular respiration. Sometimes the respiration might be irregular, sometimes you might have respiratory depression. So respiratory depression or irregular respiration, hypertension, bradycardia. And because of affectation of the oculomotor nerve, you can have a fixed, you know, dilated pupils. So the pupils becomes fixed and they become dilated because um, oculomotor supplies the parasympathetic, you know, component of the pupillary um, reflex, right? The pupillary reflex, the oculomotor branch is what is responsible for the parasympathetic supply, which allows for constriction. So that means that if the oculomotor nerve is compressed or is affected, you cannot constrict the pupils again by the time you shine your light. So it's going to remain fixed and dilated, right? And also there's affectation of drainage of like flow of CSF fluid from the optic nerve. So there is compression and kind of fluid retention within the optic nerve, leading to papilledema. So by the time you do your fundoscopy, you are seeing papilledema, you are seeing a fixed dilated pupil, you are getting features of bradycardia, hypertension, respiratory depression, and sometimes because the abducent nerve is like the nerve that has the longest course within the brain. So there's a high chance of it also getting compressed. So features of abducent nerve palsy can happen to in people with raised ICP. So we have to be very, very fast and prompt with our response to raise ICP so that we don't eventually, have the brain herniating. So there are so many things you can do to treat the raised ICP because you just want to take care of one or two or three of the brain parameters. Either you want to reduce the brain volume, you want to reduce blood flow to the brain, or you want to, draw out CSF. So if you adjust any of these three parameters, you can actually drop the ICP. So most of the time, the first thing we do is just to elevate the head, right? If you elevate the head, it's going to increase venous return from, it's going to like reduce venous return to the brain. So there's going to be like more blood leaving the brain. So there's reduction of venous return to the brain by the time you elevate the head of that patient. So you are reducing blood flow. Another thing you can do to reduce the blood flow is to sedate that patient. So by the time you sedate them, you are reducing metabolic demand, and there's a little need for blood to be delivered to the brain. So there's little vasodilation and reduction in blood flow to the brain. So that will also reduce the intracranial pressure. Or you can just hyperventilate them, which is very common. You hyperventilate them so that they can take out a lot of CO2. When they take out a lot of CO2, there's going to be vasoconstriction, because if you take out a lot of CO2, in a way, it means that you don't have any waste products in the brain, so you don't need any blood flow to take out any waste product in the brain. Do we get that? So that means that there's going to be vasoconstriction because you don't need blood. So the way I look at it is that, okay, there's less CO2, there's high oxygen. So that means that I don't need you know to have increased blood flow to the brain because there's high oxygen already and there's less CO2. So I don't need blood, right? So the vessels are going to vasoconstrict in response to that. And, there's reduction in the blood supply to the brain, right? And, that also reduce the intracranial pressure from the hyperventilation. So those are the three things you can do to reduce the blood flow to the brain. You can also reduce the blood volume and the brain volume rather. So the way you can adjust the brain volume is to give osmotic, you know, diuretic agent like giving mannitol. So if you give mannitol, it's going to draw out fluid from the brain, reducing the volume of the brain. Or to be safe, you give 3% saline, right? Which is a hypertonic saline. So that one has a little tendency of causing electrolyte shift compared to mannitol. So it's much more preferred over mannitol, to draw out fluid from the brain and reduce the brain volume, right? And lastly, you can do like, ventricular tap. You can do like external ventricular drainage to take out CSF from the brain to reduce intracranial pressure. Or you can do like a decompressive cranectomy, in which you just open a flap of the brain, allowing the brain tissue to expand so that it can decompress at the end of the day. So those are the primary mechanisms by which you can reduce the ICP. So you can do head elevation, right? Reducing the venous return, to the brain. You can hyperventilate to take out CO2, like probably like taking more oxygen so that you don't have more blood flow to the brain, from vasoconstriction. Then take out fluid from the brain by giving osmotic diuretic like IV mannitol, but be careful that this can cause electrolyte shifts and derangement. So you want to use 3% saline or hypertonic saline. So we have talked about the linear skull fractures. We are now on the epidural hematoma. So an individual suffers, trauma to the side of the head or the head, right? And the next thing the question stem tells us is that there is a loss of consciousness initially, and the person regains consciousness, right? So that is talking about the lucid interval. So you have this initial loss of consciousness, then you regain it, then you lose it again. That's typical of epidural hematoma. Now, one thing about epidural hematomas is that they are like bleeding beneath, I'm sorry, they're bleeding between the dural and the cranium above the skull, right? The periosteum of the skull. So it's epi above the dura. Now, what is covering the dura is the periosteum, right? And you have the suture lines there. So that means that the blood is actually collecting, you know, beneath the suture line. So that means that they can be limited by the suture lines because they are just under the suture line within the periosteum. So that means that they are limited, they are restricted by the suture line. That's number one. They do not cross the suture line. And because of the fact that it is actually with a tear of the middle meningeal artery, So that means that it is an arterial bleed and there's a pulsatile release of blood. So there's a high chance of the blood collecting fast and rapidly, right? So the blood is collecting fast and rapidly between the space between the dura and the skull above it. They are not crossing the suture line. They are expanding rapidly because of the arterial, source, the middle meningeal artery. So one thing about it is that once that collection is happening, the individual kind of relapses and loses consciousness. And the next thing is you are going to have compression of the uncus of the medial temporal lobe. So the medial temporal lobe of the uncus can easily get compressed, against the tentorium cerebri, which is part of the dural folding of the brain. So we should always have that at the back of our mind that one of the complications of epidural hematoma is uncal herniation. So they compress on the medial temporal lobe or the uncus of the temporal lobe, and there's affectation of the oculomotor nerve, there's affectation of the corticospinal tract. So I know Dr. Babayinde will have explained a lot of these in our neurology section, so I'm not going to start going into details, but what we are going to have is ipsilateral oculomotor nerve palsy and a contralateral hemiparesis. And in addition, there's usually affectation of the ipsilateral posterior cerebral artery. So if the posterior cerebral artery too is affected, so that means that that individual would also have features of, posterior cerebral artery problems, right? Like, the contralateral homonymous hemanopsia with macular sparing. So if we see a patient that they tell us that the patient had a trauma and there's bleed into the brain, and the patient um, lost consciousness, regains it, and loses it again. So we have established the lucid interval, which is a regaining of the consciousness, then losing it again due to the expanding hematoma from the arterial source, right? And we're able to even now locate it that it is within the side of the head. To now confirm it, we are now looking at our CT, right? And we are seeing evidence of a biconvex, biconvex collection. We can see this bright, it means this is acute bleed, and we can see the biconvex nature, right? So this is where we have the temporal lobe by the side of the brain. So that means it can easily compress on the uncus of the temporal lobe, causing problems. So so once you see this is epidural immediately, and the risk, is uncal herniation, compression of the medial temporal lobe of the brain, and they are going to have problems with the um, oculomotor nerve, the corticospinal tract, and the posterior cerebral artery. So there's ipsilateral oculomotor nerve palsy initially. There is contralateral weakness, right? So there's a mistake here. So they said patient undergoes a lutein which becomes comatose, right? Examination may show ipsilateral blown pupils. No, and yeah, ipsilateral blown pupils and ipsilateral hemiparesis. So this ipsilateral hemiparesis is wrong. It's going to be contralateral hemiparesis initially at the early stage. So there's going to be problems within the oculomotor nerve on the ipsilateral side, and the contralateral side is going to be weak, right? So the reason is that that this bleeding now is happening just um, in the brain, before you have decussation of the corticospinal tract at the level of the medulla. So it means that if, let's say that this is the right side, right, you're having a bleed in the right side, so that means that it's going to affect the right oculomotor nerve, right? And there's going to be affectation of the right corticospinal tract. But later, when the corticospinal tract leaves the cerebral cortex and descends downwards through the medulla, it's going to decussate to supply the left side. So that means that if you have affected the right corticospinal tract upstream the medulla, it means that by the time it's decussating, through the medulla, there's going to be paralysis of the left side. So that's why there's usually a left-sided hemiparesis, because this compression occurs above the medulla. That is it. So it occurs above the medulla. So that is why you are going to have a contralateral hemiparesis. But later, due to the Keynesian phenomenon, it's going to change, right? It's going to change due to the contralateral push. So you are now going to have a reverse at the later, which is the Kenoa phenomenon, in which you have contralateral oculomotor nerve palsy and ipsilateral hemiparesis. So we can learn that when we revise our neurology section. So watch out for that. Watch out for that. And how are you going to treat individuals with epidural hematoma? So if you have any patient with epidural hematoma that is presenting with symptoms, the headaches, the vomiting, the focal neurologic deficit, right? Maybe aphasia, problems with moving one part of the body and the likes, vision issues, depending on the location, right? You have to do an emergency decompressive, um, an emergency craniotomy. So craniotomy, not craniectomy, craniotomy. So you are making a hole in the brain and you are evacuating the hematoma. That is it. So you usually do it for people with large epidural collection with symptoms. But if it's small, if the collection is small and the patient is asymptomatic, you can just monitor the patient, with multiple CT scans every 6 to 8 hourly, right? That's just what you do, But if there's symptoms and it is large, you have to remove it immediately. You do your craniotomy, putting a hole in the skull, evacuating the hematoma. So this is the one for the subdural, and this is more like a crescentic collection, like moon shaped, right? Half a moon collection, not biconvex like this. So subdural hematoma usually occurs beneath the dural matter, so not above the dural. So between the dural space and the epidural region. So the space between the dural and the epidural and the arachnoid region. So the space between the dural and the arachnoid matter is where you have subdural hematoma, sub beneath the dural. And what is next to the dural is what? The arachnoid layer. So it collects between the dural and the arachnoid layer. And this one is actually with the tear of the bridging veins, the bridging veins of the subdural space. It's very common in people that are old, people that have their brain shrunken, babies, right? Babies, people that are alcoholics, or people that are on anticoagulants, right? So it usually occurs when there's any condition that increase the diameter of the subdural space. When the brain volume reduces, the diameter of the subdural space increases, and the distance the bridging veins are going to travel increases because they travel across the subdural space. So that means that they are prone to tears, right? Causing the subdural bleed. So this one is located beneath, the dura, and it's not even near the skull. So that means that there's no way it's going to be confined by the suture line. So it will cross the suture line, right? But it doesn't happen as acutely, as epidural, because this is from a venous bleed. So most of the time you just get like small leaks, right? So most of the time you don't get acute presentation, but you might get acute presentation depending on the severity. So sometimes you might present with their symptoms acutely, with immediately, subacute within days, or chronic within weeks. So elderly people usually have their own to be chronic. So later they just start having the reduced consciousness, the dizziness, the weakness, the hemiparesis, depending, aphasia, anything. They can have anything, right? So don't forget the subdural does not um, crosses the suture line because it's not confined by the suture line. Crosses the suture line, you know, there's no lucid interval here, right? So, and by the time you do your CT, your non-contrast CT scan, you are going to see the crescentic collection, right? You are going to see the crescentic collection. So you have to step in to do surgery when the hematoma is big enough to cause like a midline shift, right? You are seeing a midline shift of more than 5 millimeters, right? Or the person is presenting with signs and symptoms of neurologic deficit, you know, or the person is already showing signs and symptoms of ICP, so elevation. You have to step in immediately and do the same thing you do in epidural. You do your craniotomy and you evacuate the hematoma. So what is just important here is that this one is from a vein, the bridging vein, while epidural is from the middle meningeal artery. And you don't have any lucid interval here in the subdural. The subdural is very common in people that are old, unlike in epidural, that is very common in people that are young, right? You can get subdural in babies, to babies that have what we call shaking baby syndrome. They have been kind of traumatized by constant um um uh how do I put it, like constant shaking. The acceleration deceleration movement of the head can tear these fragile veins, and they can have subdural hematoma, they can have retinal hemorrhages, and they start presenting with seizures and the likes. So don't forget, you have to do craniotomy if the CT scan shows a midline shift of more than 5 millimeters, or there's a worsening neurologic symptoms of mental status. You also have to make sure you are managing your ICP, which you have talked about initially, and you want to be careful with the giving of fluids because you want to limit cerebral edema. So very easy to identify. The next one is diffuse axonal injury. So diffuse axonal injury is very common in people that suffer the sudden acceleration, deceleration, or more like a rotational injury. So probably maybe somebody is moving at high speed and suddenly matches a brake. So they are accelerating initially, and suddenly just decelerate back. So that forward backward movement of the head, or like a rotational movement of the head, can shear away the axons of the neurons. And the axons basically constitute the white matter because they are myelinated, so they appear white. Myelin is white. So there's sharing of the axons, and the problems usually manifest more at the junction between the gray and the white matter. So, but it's majorly the white matter that is damaged, but you see it at the junction between the gray and the white matter. So, um, so how do they usually present? People with diffuse axonal injury usually have like a widespread injury to the brain. So it's a very serious problem. Most of the time, they don't even start with having, you what's it called, focal neurologic deficit or something. Like most of the time, they go into like a persistent vegetative state or coma immediately. Is that bad? So, and the bad part of this is that if you do your imaging, what you are going to see is not going to commensurate with the clinical presentation because the individual is going to be in coma. And by the time you do your imaging, you might not even see anything on CT. So the best way to pick diffuse axonal injury is to do your MRI. And what you are going to see in MRI is that number one, you are going to observe blurring of the gray white matter junction. That's number one. It's going to be blur because that's where the injury is happening. And number two is that you are going to see punctate hemorrhage, bleeding, small bleeding from the white matter. From the white matter. So once you get history that somebody was involved in an accident and suddenly the GCS score was like 8 below, right? Of course, you are going to intubate that patient, right? And the patient was just comatose after that injury, and you did your imaging, your MRI, you are seeing features of punctate hemorrhage, or you are seeing blurring of the gray white matter junction, and you are not seeing any hematoma, any blood collection. You are dealing with diffuse axonal injury. So what you want to do is just to resuscitate, the normal ABCD, airway, breathing, circulation. Then you try to prevent secondary injury, your raised ICP, because they have a very high chance of having cerebral edema with raised ICP. So what you want to quickly do is to quickly manage that raised ICP to prevent brain herniation, and you just, give them oxygen, ensure that they are breathing, their circulation is intact. There's no other secondary injury that's happening that you have not taken care of. And from there, they are going to recover sometimes. So then you can now start doing rehabilitation to achieve maximal functional outcome, because it's not very easy to get out of this situation. They still need to do some lot of physiotherapy and the likes, because most of the time they move straight to coma. So you just have to do your own initial resuscitation and hope they come out of the condition. So, and you want to prevent secondary injuries, basically like brain herniation from the raised ICP majorly. You want to ensure that they are euglycemic, they are normothermic, so that those doesn't worsen the problems. So, um, manage your ICP, reduce cerebral edema so that they don't have brain herniation and they don't, die at the end of the day. So that's basically what you do. Supportive treatment. That's basically what you do for diffuse axonal injury. You are not going there to evacuate any hematoma. There's no hematoma to evacuate. Then moving on to basilar skull fracture. So the basilar skull fracture is just fracture of the bones that makes up the base of the skull, right? The ethmoid bone, the orbital plate of frontal bone, the petrous and the squamous temporal bone, the sphenoid and the occipital bone. Yeah, it's good to know all these bones, but nobody is really going to ask us, the individual bones, right? So we should just know that it's usually associated with like high impact, blunt force trauma to the brain. And most of the time, it is the temporal bone that is affected. Because the temporal bone kind of forms a big chunk. It forms a big chunk of the base of the skull, right? The petrous part, the squamous part, they all contribute to the base of the skull. So it might affect the temporal bone. And when there's affectation of the temporal bone, it is not uncommon for them to have epidural hematoma alongside with this skull fracture. So because of the fact that that the temporal bone is very close to the medial meningeal artery, they can have a tear of the medial meningeal artery and they can have epidural hematomas with it. So what are the signs we have to look out for? So basal skull fracture is very easy to diagnose in questions because you are going to see the features of the subcutaneous hematomas, the subcutaneous collections, and the leukorrhea. So for the subcutaneous collections, you are just looking for evidence of bleeding into the periorbital region, so periorbital ecchymosis, right? Um, which is what we call the raccoon eyes. You see bleeding into the orbit, right? Or they can have bleeding at the back of the mastoid process. So they can have a post-auricular bleed or a mastoid ecchymosis, which you call the Bartle sign. So the mastoid process is part of the bone of is part of the projections from the temporal bone. So they can have bleeding into the mastoid process at the back of the head. That's what we call the Bartle sign. They can have bleeding into the eyes, which is the periorbital ecchymosis. They can have bleeding into the hair, which is hemotympanum. So watch out for those three things. A patient presenting with hemotympanum, presenting with periorbital ecchymosis, presenting with bleeding at the back of the hair, which is mastoid ecchymosis. You know that this is likely to be basal skull fracture, right? And you now also watch out for the leukorrhea. Any bleeding, any discharge, any clear watery discharge from the hair, which is the otorrhea, or any clear watery discharge from the nose, which is the rhinorrhea. CSF leak, very common in people with basal skull fracture. So once you see any of these features, it raises suspicion for basal skull fracture. So there's no cause for alarm, basically. You can further make your diagnosis by doing your CSF leak testing. So you just place a drop of the leukorrhea, on a absorbent paper, and you are going to notice that the blood will gravitate towards the center of the paper, and it's going to be surrounded by a clear fluid, which is the CSF. So that is one test you can do, or you can just measure the quantity of beta transferrin in that discharge, because beta transferrin is very, very abundant in CSF. So don't forget, beta transferrin, beta transferrin is very, very abundant in CSF. So once you get the drainage from the hair, the drainage from the nose, you test it for beta transferrin and it is high, you know that is likely to be a CSF leak. So most of the time you don't do any active stuff, you just do like supportive care, because the basal skull fracture, they heal on their own, right? You just have them on admission, you observe them to see if there's going to be any deterioration of their mental status. Maybe they become more somnolent, they become agitated or the likes, or they start having intracranial bleeding, because you have said it that they can have epidural hematoma. So you have to watch out for any form of intracranial bleeding, but after a while, if they are stable, you can discharge them, because most of the basal skull fracture, they will heal spontaneously. They don't require any active treatment. But if this individual is having persistent CSF leakage, the CSF is still leaking for more than 7 days, you have to do a surgical repair. You have to close it surgically, repair those fractures surgically, because of the risk of meningitis. That break in the skull is going to allow the organism ascend to the brain, particularly strep pneumo. They can easily ascend to the brain and they can cause um meningitis. So that's why sometimes people with this kind of skull fracture, you want to place them on like pneumococcal vaccines, to reduce the incidence of having pneumococcal meningitis. So moving on to pediatric traumatic brain injury, it's just basically essentially the same as everything we have been talking about. They can have everything we have talked about initially. They can have a contusion, they can have concussion, they can have epidural, subdural bleeding. They can have diffuse axonal injury, right? Although subdural is very common in them, subdural is very common in them, and we have to pay attention to the mechanism of injury. Very, very important. So any child that experiences a fall from height as high as like about 1.5 meters or more, motor vehicle, accident, child abuse, those are high risk, for traumatic brain injury in pediatric population. So you have to pay attention to that in your history. What you are taking, what is the mechanism of injury? Is it high risk? Because if it's high risk, it's an indication for imaging. You have to do like a CT scan, non-contrast imaging, non-contrast CT scan of the head to evaluate for any intracranial bleeding in those guys. So even there are some children that um might not be showing signs, but from the mechanism, it's pointing towards, you know, um, sorry, um, what I'm saying is sometimes you might have like a baby that maybe the mechanism of injury is not very severe, but maybe the presentation, probably they're having headaches, they're having constant vomiting, or you are seeing features of like basal skull fracture, it's bleeding into the eyes. You need to do imaging. So that's what I'm trying to drive home there. So the number one thing that is very important is the mechanism. Get the mechanism. What is the mechanism? It's a fall from certain height more than 1.5, motor vehicle collisions, child abuse. You have to do imaging. Sometimes they might not have these mechanisms, but from your own clinical findings, it's pointing towards, a very, very high risk for, severe TBI, probably from what we have been saying, you know, worsening of the sensorium, neurologic deficit, constant headaches and vomiting, all those things will still prompt evaluation, even if the mechanism of injury is not suggestive of, high risk. So particularly children with, signal loss of consciousness, altered sensorium, vomiting, headache. So I have an acronym. We have to, not an acronym, but some list of features that we have to pay attention to. I think I should have it here. That will guide the need for imaging. So we call it the Pecan rule. So the pediatric CT of the head, imaging rule. So any child that is less than 2 years, right, and is having any of these should get a CT scan, a non-contrast enhanced CT scan. Any child that's less than 2 years having any one of these. So the way I just note it is just having um three things first, which is the altered sensorium, the loss of consciousness, and the mechanism of injury, regardless of the age. Altered sensorium, loss of consciousness, and the mechanism of injury. So if there is altered mental status, like maybe the child is becoming fuzzy or somnolent, agitated, I know that okay, there's some altered sensorium. Child needs to get imaging. If there's loss of consciousness, worsening loss of consciousness. So if there's any form of loss of consciousness at all, that child must get imaging. The mechanism of injury, it fall from like a height of like 0.9 for children less than 2 years, or more than 1.5 for children more than 2 years. Definitely, they have to get imaging. High impact injury, motor vehicle accident, they have to get imaging. Now, what now distinguishes people less than 2 years from people more than 2 years now? Additional two features. Number one, for the less than 2 years, if they have any form of non-frontal scalp hematoma, if there's any scalp hematoma, any hematoma collection within the scalp, but it's not in the frontal area, they have to get, because the ones in the frontal are not, it has been shown that it's not very associated with, high risk injury to the brain. But the non-frontal or anywhere else, get it, get the CT scan. If you can palpate any skull fracture, palpable skull fracture, get CT scan. So the first three things, the mechanism of injury, altered sensorium, loss of consciousness, then the palpable skull fracture, the non-frontal skull hematoma, you have to get CT for a child less than 2 years. But if it's more than 2 to 18, because they can have vomiting, they can complain of headache, anybody more than 2 years. So in those guys, you have to pay attention to the need for CT, and if they have any feature of basal skull fracture, CSF rhinorrhea, autoria, the Patu sign, the periorbital ecchymosis, get your CT scan done. So those are the rules for pediatric CT scan, in the indication. So um you have to do like a thorough neurologic examination, check their GCS score. Anybody with GCS score less than 8, intubate. Sometimes the CT scan may be normal, particularly in people with diffuse axonal injury that we have mentioned. So you might want to do, um, an MRI to look for features of axonal sharing, like blunting of the gray-white matter junction, punctate hemorrhages, particularly if you have done your CT scan and you are not seeing any hematoma, and the person is still in a like vegetated comatose state, you know that that's likely to be diffuse axonal injury. So it warrants a more specific investigation modality like the MRI. So we have talked about the need for intubation if the GCS score is 8 or less, right? Sometimes you might need to place a cervical spine injury. Usually from the mechanism of injury, you will know if there's a need for this cervical spine. We have talked about the diffuse axonal injury to occur with sudden acceleration, deceleration, or rotational forces, which causes the sharing of the white matter between the junction between the gray and the white matter. So the sharing of the axons, between the junction of the gray and the white matter. So that junction is going to be appearing in blood on your MRI, right? So, and most of the time, because it causes a global injury to the brain, there's going to be, a progression to coma. So most of them, they progress to coma. So it's very common in children that experience eye fall, motor vehicle accident, or abuse, like in shaking baby syndrome. So very, very important. Very, very important we pay attention to that. And just like I've said earlier, they can have myriads of stuff. Brain contusion, interparenchymal memory, subdural hematoma, anyone you can think of. They can have any one of them, and you manage them accordingly. And one thing that we also need to know is that children, when they experience traumatic brain injury, they tend to have a reduction in cerebral perfusion, because the problem in them is that the autoregulatory mechanism is not well developed. So once there's any bleeding, there's cerebral hypoperfusion immediately, because the brain cannot adjust its autoregulatory mechanism to further perfuse the brain in response to that injury. So, and when um, there's going to be increased metabolic demand, there's going to be reduced perfusion, and at the end of the day, this is going to lead to hypoxia. So they can even have a worsened secondary brain injury from hypoxic insult, right? So, and at the same time, they also have a high incidence of having diffuse cerebral swelling, and the mechanism is not actually well known. So the mainstay, because you already have it at the back of your mind that, okay, these individuals can have diffuse cerebral swelling, they can have hypoxic injury because of the reduced cerebral perfusion. So the first thing that will come to our mind is a need for fluid resuscitation. So you have a child that's being brought to the emergency and there's a history of TBI. One of those things that should come to our mind is what? Fluid resuscitation, because of the increased risk of secondary hypoxic injury from the reduced cerebral perfusion. So you have to ensure that you are diligent with your fluid resuscitation. And if that child is on any antihypertensive, you have to avoid giving on, there's even little chance of a child being on antihypertensive, but you must avoid giving them antihypertensive so that you don't further reduce the blood pressure that is already maintaining the cerebral perfusion. So be diligent with your fluid resuscitation, avoid antihypertensive to avoid hypoperfusion and secondary ischemic or hypoxic brain injury. Very, very important. So the take home is just knowing the Peckham rule, you know, for a need for investigation, because that's where the question is going to be emphasizing most of the time. You want to know if you know what are the things that prompt imaging in a child, right? Identifying those salient features you have talked about, like altered sensorium, loss of consciousness, the mechanism of injury, the height, falling from height, motor vehicle accident, abuse, um, um, then the last two, depending on the age. So if it's someone that's less than 2 years, you want to, check, do you have any palpable skull fracture, or there's a non-frontal, scalp hematoma? You have to do a CT scan. Or if it's the older one, they can have headache, they can have vomiting, or they have any features of basal skull fracture, do imaging there. Okay, so moving on to the Lifford fracture. So the Lifford fracture is just essentially talking about injuries to the face, right? Fractures of the midface. Now, one thing that is common to the midface injury, the Lifford fracture, is that they posteriorly go to the pterygoid plate of the maxilla. We don't need to actually palm all these things. We are not dental students. And, we don't need to be looking at those anatomy. Just have a simple picture of, what it looks like. So these are the collection of the Lifford fracture. Very easy stuff. One thing I just want to say is that um, it occurs in three different categories. So you can have Lifford fracture 1, that's one level. It's like the mildest. And you have another one which is Lifford 2, which is more severe, and the Lifford 3. So you are moving from down to up. There are some landmarks that we need to identify, that once you're able to get those landmarks, you can classify them into the level. So the Lifford fracture 1, and one thing I have to emphasize before I start is that all of them having the fracture passing through the pterygoid process or the pterygoid plate of the maxillar bone. That's the first thing that we need to have in our back of our mind. So if they tell us that, okay, which structure is constantly affected in people with the Lifford fractures or people with the fractures of the midface, right? So the first thing is what? The pterygoid plate. Constant stuff. So we cannot really appreciate it here because it's at the back, it's posterior stuff. So the Lifford fracture 1 is called a transverse, fracture, and it passes through the maxilla. So this is the maxilla bone, right? It passes through the maxilla horizontally across the nasal aperture. So it's moving from the lateral aspect of the maxilla, then across the nasal aperture to the other end. Now, this kind of fracture would cause malocclusion. That's a problem of Lifford fracture 1. It causes malocclusion because if have a fracture across the maxilla affecting the heart palate, there's going to be like a malalignment of the maxillar bone with the mandible. So this individual will having problems, speaking. They can have problems even eating, right? They can have problems breathing because sometimes there is a chance of maxillary impaction in which you just have destruction of this, nasal anatomy affecting the airways. You can also have actually soft tissue swelling, occluding the airways, and they have difficulty in breathing. So that's Lifford fracture 1. Very easy. A low transverse fracture passing through the nasal aperture. Very, very easy. Very, very easy. So these individuals can present with swelling of the upper lip because this is very close to the upper lip. The upper lip is just here. So they can have swelling of the upper lip. They can have, because this is around the buccal mucosa, this is around the cheek. So they can have like bruising of the buccal mucosa. They are going to have malocclusion, right? They will tell you that you can also see that there's like a malalignment, especially when they are taking bites between the upper jaw and the lower jaw because of the fracture. And if you try to do your locking maneuver, so the surgeon is going to place the hand on this part, and the surgeon is going to place the hand beneath the heart palate, and you tend to pull in and outward. You notice that there's a isolated movement of the maxilla. Once you have that, that is Lifford fracture 1. Very easy. So don't forget the landmark, the nasal aperture. Then the next is the Lifford fracture 2. So Lifford fracture 2, the landmark here is actually like the infraorbital rim. So you are having a fracture that is beginning at the lateral vestibular, processes. Somewhere here, the lateral vestibular regions of the maxilla moving upwards through the infraorbital rim. You can see it here, the infraorbital rim, then adjoining to the other side of the face. passing across the nasal bone, passing across the nasal, septum, moving from the lateral vertebral, turbinate, ascending to the infraorbital rim, moving through the nasal septum, then to the contralateral side. So it always passes through the infraorbital rim. Very, very important. Like we can appreciate here. Now, this is the infraorbital foramen. This is where the infraorbital nerve, which is a branch of the maxillary nerve, passes through. So it means that there's a tendency of this fracture affecting the infraorbital nerve. So, and that infraorbital nerve is purely sensory, right? Of course, we know the trigeminal nerve. So the maxillary part is, sensory, and what it does is to supply the this part of the face, the lower part of um the infraorbital region, right? It supplies the upper part of the lips. It supplies part of the nose. It supplies the cheek. So that means that they can tell us that there is a loss of sensation within those areas. There's a loss of sensation within the infraorbital region. There's a loss of sensation within the upper lip. There's also sensation within the lateral part of the nose or the cheek. You know that the infraorbital nerve is gone. And that is very common in people with the leaf or true fracture because it can pass through that area, right? Because it moves across the infraorbital, rim. Then the third, which is, and what I'm going to say before I leave leaf fracture 2 is that they can present with all the signs of people with leaf fracture 1, right? Because it affects the maxilla too. It affects the maxilla, so they can have malocclusion, right? It passes through the orbit, right? So they can have periorbital ecchymosis, they can have periorbital bleeding, right? It passes through the nose. They can have epistasis. They can have epistasis, and you are going to see bruising, malalignment of the midface because this is taking the entire midface. And now, if the surgeon does the maneuver, the rocking maneuver, how the surgeon will distinguish this from leaf fracture 1 is that by the time the surgeon places the hand here and in the palate and he try to shake the maxilla, rock it forward and backward, instead of the maxilla moving in isolation, this one is going to be moving with both the nose and the maxilla. So if there's movement of the maxilla in conjunction with the nose, you think of leaf fracture 2, right? Because look at the fracture. It is taking the maxilla. This is the maxilla. It is taking the maxilla with the nose. This is the nose, right? But look at leaf fracture 1. It is only the maxilla that is being taken, right? So the nose is going to be fixed in leaf fracture 1. But in leaf fracture 2, it is taking this part, which is the maxilla and the nose. So both of them is going to move together, separating, separated from the rest of the skull. Then the third one, which is the most severe, is the leaf fracture 3, right? So this one usually involves like the zygomatic process, right? The cheekbone. So to affect the zygomatic process, you have that fracture starting moving inward into the lateral and the medial part of the orbit. So there's a like zygomatic process moving inward into the lateral and the medial part of the orbit, moving across the nasal septum to the other side. So this one is basically inside the eyes. So that is why if you get history of somebody with a leaf fracture, a midface fracture, and the person is having enophthalmos, right? Inward sucking in of the eyeballs. Think about leaf fracture 3. Think about leaf fracture 3. And because this kind of move inwards, there's a high chance of them having basal skull fracture because here, like most of the bones that form the base of the skull are like within this vicinity. The ethmoid bone, the temporal bone, the sphenoid, most of them are like within this vicinity. So because this is where the base of the skull is, you can just open it from up. Oh, I wish there's a way I can show this. This like just have a picture that there's a line here, and you can just open it because that's where the base of the skull is. The remaining that you have beneath, if this is the line for the base of the skull, the remaining here is what we call the viscerocranium. The upper part is the neurocranium. So So because this is kind of delineating like the base of the skull, you know, people with the leaf fracture 3 usually have signs and features of the basal skull fracture, like the hemotympanum. They have, CSF drainage from the nose, from the hair, battle sign, and the likes. So once you are getting enophthalmos, you are seeing like increase in the diameter of the intercanthal space. This is the intercanthal space, distance between the medial, orbital aperture. So here is widened. If they tell you that that space is widened, or the patient is having enophthalmos, or there is hemotympanum, there is a CNF granuria, think about leaf fracture 3. Think about leaf fracture 3. So that is that about the classification of the fractures, and essentially what you just need to do is just to do open reduction and internal fixation. You have to do your HORIF, right? Sometimes you might have them having like a mandibular displacement. So in such individuals, you need to do what we call like an intermaxillary fixation, or what we call a maxillary mandibular fixation. So what you are going to do is that you are going to fix the mandible with the maxilla using some like wires. So they are going to join it together, bam, after you have done your HORIF. So let's go back to the image so that I'm not just be, speaking blindly. So um the Lefort fractures, just to classify the fractures of the midface, right? Just like we have said, and most of them they extend posteriorly through the pterygoid plates, separating the maxilla from the cranium. So all of them, all the Lefort fracture runs through the pterygoid plate, right? And the classification is based on the different patterns of the passage of the fracture lines along the anterior bones of the midface. So one thing that you have to worry about is airway compromise, just like I've said, due to maxillary impaction. So because most of them, they passes through the maxilla. The maxilla forms part of the, very close to the nose, so it can distort the nasal anatomy. And because of the associated soft tissue edema and swelling, it can also compromise the airway. So you must pay attention to the airway management in people with Lefort fractures of the face, right? So if there's a problem with the airway, you need to quickly do your initial resuscitation and drive the way to disimpact that displaced segment that is obstructing the airway, and you have to do a reassessment of the airway. So but you are not going to worry about disimpaction first. The first thing is to provide a temporary airway. Probably you are going to do like um what's it called, you do your maybe endotracheal intubation, you do your cricothyroidectomy, make a hole there, the cricothyroid membrane, make a hole, or you do an intraoral intubation, provide a temporary airway while you are now, looking for a way to disimpact the displaced segment by the surgeon, right? So we have talked about what happens in Lefort fracture 1. It's basically a transverse fracture that passes through the maxilla, right? Inferior to the zygoma. So zygoma is just like one part of the bone that forms the cheek, right? So, but it passes through the nasal aperture. Don't forget, that is a landmark. It passes through the nasal aperture. And physical examination is notable for mobility of the maxilla only. Please don't forget, the maxilla only with the rocking maneuver, right? And there's going to be malocclusion. So you notice that the upper and the lower jaw, they are not aligned. The person is going to be having problem with even taking bites, right? Because of the malocclusion, very common stuff. There's going to be bruising of the muca mucosa. There's going to be edema of the upper lips, right? Very common in Lefort fracture 1. The Lefort fracture 2, it's more like a pyramidal fracture. So it takes a shape of the pyramid, because if you look at the picture, just like I've shown, I showed us the other time, it um you know what do you have here? So you can have, the starting from here, the this lateral part of the maxilla, ascending upwards through the infraorbital ring, right, passing across the nasal septum to the contralateral side. So very, very important stuff we have to pay attention to. um you know so it gives shape of a pyramid. Let's see. So this is it. This is like, a pyramid, a pyramidal pattern. um the pyramidal pattern, involving the nasal bridge, which we have talked about, the medial part of the orbit, which is formed by the lacrimal bone, the medial orbital floor, and the lateral wall of the maxillary sinus. So we have said it. It does start from the lateral wall of the maxillary sinus, passes through the inferior orbital rim, the nasal bridge, then the contralateral side, entering to the medial and the lateral part of the orbit again, coming downwards to the inferior orbital, rim, then to the lateral part of the maxilla. So, excuse me. So, then the third one is the leaf fracture 3. So, which basically runs through the orbit. So it runs through the orbit across the nasal bridge, involving the frontozygomatic suture. So somewhere here you have the frontozygomatic suture. So the frontal bone and the zygomatic bone, that's just what it means. There's a suture here that joins the frontal bone here and the zygomatic bone. So it runs from that area, into the orbit, right? The orbital plate, then across the nasal bone to the contralateral side. So don't forget the enophthalmos, don't forget the features of the basal skull fracture. Very, very important. So we can have it here. These injuries are commonly associated with basal skull fractures. It's here. So, and physical examination is notable for complete instability of the midface on the rocking maneuvers. So, running over the rocking maneuvers again, by the time the question stem tells us that the surgeon does the rocking maneuver and there's isolated movement of the maxilla only, leaf fracture 1. There's isolated movement of both the maxilla and the nose, leaf fracture 2. But if there is like movement of all the entire midface separated from the skull, so like everything beneath this line, so this is this line now, right? Everything beneath here, is moving in isolation, separated from the cranium. So this is what we call a craniofacial separation in leaf fracture 3. Cranial, meaning that everything here is separated from everything beneath, because this is a visceral cranium, the facial bone. That's what we call the visceral cranium. So they are separated from the skull. So that's what you call a craniofacial separation. So that's what you have in leaf fracture 3. So don't forget that, it's more like a complete instability of the midface in leaf fracture 3. It's actually with basal skull fracture, very important stuff. Both the leaf fracture 3 and leaf fracture 2 can also damage the infraorbital nerve, but it's very common with leaf fracture 2, right? And what you do to treat all these fractures, because you are more concerned with the ability of this individual to speak, with the ability of this individual to feed, rather than the cosmetic disfigurement. That's your major concern. And what you have to do is do an open reduction and surgical fixation, which usually we plate. So you put some plates, some screws, doing your open reduction and surgical fixation, so that you can, achieve proper alignment and stability of this fractured area, especially, in especially after you have corrected other life-threatening problems like difficulty in breathing, your airway management, and the likes. If there's any bleeding ongoing, you secure your hemostasis. If there's any problem with the breathing, ventilation, you do your airway assessment and airway resuscitation. Then you can now look into doing surgery later, which is the open reduction and the surgical fixation of the midface, right? So you have to approximate those dental occlusive surface, which is your mainstay of your reduction and fixation. So you make sure that they are reapproximated together, they are attached together. That's what they are trying to say. They attach those fractures, they are together, so that everything can be moving in unison, right? In some situations, you can have the mandible also being displaced. Remember that when we are talking about the major leaf fracture, we are not talking about the mandible, but based on the impact of the trauma, sometimes the mandible can be affected. So you have to fix the maxilla with the mandible. So, and that is what we call the, I think we have it here. Oh, we don't have it here. The mandibulomaxillar fixation. So let me see if I can, check it out for us online. Okay. Probably we can just Google it so that I don't cause, we can just check it out. Mandibulomaxillar fixation. So you are fixing the mandible and the maxilla together with some wires, fixing them together so that they are properly aligned. And that is going to cause problem for the patient because the patient is not going to be eating, not going to be speaking for some time, for about 6 to 8 weeks, right? So you can just be giving that patient liquid diet until you can escalate to, a more solid food later. So don't forget, the mainstay of treatment is your HORIF. If there's problem with the mandible, you can do your mandibular maxillar fixation alongside with the HORIF. So that's that about blunt trauma to the head.